and share my screen. Tell me if you see my screen now.
Yes, yes, yes.
Okay, so let me move into full screen so that you will have, I think, a better view on the presentation. Here we go. Can you see the slides?
Yes, I can see
Okay.
that.
Okay, perfect. And I don't think I have a complete view of it. By the way, for all the participants, feel free to raise your hand in the course of the presentation to ask questions if you want. I'm not sure if I can see well if someone is raising his or her hand, but anyway. Fershte, I'll rely on you in case someone would like to ask a question as we're progressing. Okay.
Okay. Thank you very much. Thank you very much.
So thanks for inviting me to speak at this webinar. The subject is about innovation in the field of vaccines for older citizens, which we refer to as subjects in the field of vaccines, because for preventative vaccines you immunize healthy people. So we're not talking about patients. We're talking about subjects, even though they may actually have otherwise some comorbidities. A few words about myself. I run an advisory company based in Geneva. I have a part-time business activity with a Chinese company which is involved in the search for a coronavirus vaccine, which is one of the actually quite advanced ones currently in phase 3. And besides this, I have board director roles in various companies, all of them in life science. Teradia is a French company in vitro diagnostics. Eurocin Vaccines is a Swedish company in adjuvants for immunotherapy. My CB1 is a Dutch company in medical cannabis. Vaccitech is a British vaccine company for cancer and infectious diseases, and Univercells is a Belgian company for the production of biologics, ranging from monoclonal antibodies to cell and gene therapy. And besides this, I do a little bit of investment advisory as the partner for Switzerland in a French family office which invests in medtech, so that's Mary Equity Partners. I'm the chairman of an Italian family office which invests in early stage life science, and I'm mentoring companies that are into the MIT incubator, which is based next to where I live in Switzerland. So considering the subject of the day, and there's always a lot of I would say reactions or comments when it comes to vaccines. So please make note that the way I present beyond the data, the way I present the content of this presentation is entirely my opinion, and there's one looks like I see some conversation points.
Yes, because you are the new host, I ask you when Sven and Katarina is connecting. Please, please choose them so they can speak.
Okay.
Yeah, enable their microphone, Sven and Katarina. I think they are connecting.
Okay. And so this is the usual disclaimer. So let me get started with the presentation itself. So I mean, because of the nature of the subject, I felt it was important to start with a little crash course on what is immunosenescence, meaning the aging of the immune system, and because that actually leads into the key considerations to understand in terms of how do you assess vaccine effectiveness in seniors, and are there any novel technologies that help enhance the efficacy of vaccines in seniors. And that matters, especially in the current situation, because as everybody knows, this coronavirus is actually having a higher morbidity and mortality in senior people, and therefore making sure that they're efficiently protected matters a lot. So moving on into the presentation, first some considerations there. So the key notion to keep in mind is that the immune system is, I mean, something that has been evolving over millions of years, right? It was already in place in animals, and then what we inherit is a very complex system honed by nature over the phases of evolution. And it's important to keep in mind that there's a lot of crosstalk between all the components of the immune system. Therefore, if you induce a dysfunction in a single population of immune cells, it has a domino effect across other cell subsets. And you've got a number of innate immune cells, and neutrophils and macrophages, dendritic cells, etc. And they're all involved one way or the other in the early phases of the immune response, especially the macrophages and the dendritic cells, because they play a key role at the initiation of an adaptive immune response, because they capture the pathogen or they capture the content of the vaccine, and they present the antigen to the T cells, and therefore they induce the immune cascade. And of course, also the so-called helper T cells are absolutely critical to have a B cell response. And as you know, the B cells are those that actually enhance the starting point of the antibody response. So this is just a simple schematic representation that all those cell populations are linked to each other. So in case of a dysregulation or an insufficient functioning, it creates an imbalance and therefore a suboptimal response of the immune system, either to an infection, meaning you're less protected, or to a vaccine, meaning you're also less protected against the disease. Now, why does it matter? Well, it matters because so far the percentage of the world population which is aged over 60 is 11%. It is forecasted to be in excess of 1/5 of the world population by 2050. And mind you, at the age of 60 today, nobody believes he's old, right? And people want to age young, but they're immune. Sorry?
Definitely, yes, that's true.
And so it does matter to actually understand how to protect this growing chunk of the population. Of course, besides the senescence of the immune system, the more you age, the more you have other diseases, cardiovascular, respiratory, and those are also having a compounding impact on the susceptibility to infection. Okay, so you not only have, even in an otherwise healthy senior, a higher risk of infectious diseases because of the aging of the immune system, but if on top of it you have, respiratory insufficiency, type 2 diabetes, cardiac insufficiency, all those are conditions that are actually increase the exposure and potentially lower the quality of the prognosis in case of an infection. So what you see in older people is you see an inverse CD4-CD8 ratio. So the CD4s are the T cells that stimulate the B cells to produce the antibodies, whereas the CD8s are the so-called killer cells that actually kill the infected cells. And you get in seniors less CD8s, and you have also less naive T cells. So you're deprived of the population that you want to actually initiate the immune memory against a new pathogen. And why? Because essentially you have T cells are well differentiated, but they don't have the capability to, the agility to be primed to a new target. And those tend to multiply, but then you get decent protection against older infections, but you don't get such as good protection against newer infections. And also the NK cells are also altered. So long story short, what do you want when you actually develop a vaccine for seniors is you want to overcome those alterations, and you need to therefore design a drug, because essentially from the regulatory perspective, a vaccine is a medication, it's a drug. You want to design it in such a way that it actually overcomes those limitations. So that takes us into, what is it that you're seeking when you're talking about the effectiveness of vaccine in seniors? What you want to get is this kind of outcome. So this is something which is, I think, a very telling graph. It shows the mortality. So apologies because it's a French graph, French data from the French National Institute of Health, which shows in the blue line or curve the mortality linked to influenza in the people of 75 years or older. And what you have in the brown square line is the progressive introduction of the influenza vaccine. And on the right-hand scale, you got the percentage of vaccination in the target population of 75 years or more. And as you can see, there is a direct correlation between introduction of the vaccine and reaching a sufficient coverage, so 60% or above, and really collapsing the mortality into the seniors. So with all its limitations, and of course, the efficacy varies from year to year due to the way this vaccine is manufactured, and I'm happy to elaborate on this. The influenza vaccine is a perfect illustration that you can reduce morbidity and mortality in seniors if you have a very active immunization campaign and if you reach a sufficient coverage. Now, what is interesting, and this is across a number of countries, and you got the reference there. It's when you look at the influenza vaccine coverage, and this was from 2012 to 2015, and you got colored bars for the various campaigns, and this is all North Hemisphere. What you can see is that the overall target population, and that's across essentially European countries. Essentially, it's the average is 30% of the population is covered, and in seniors, it's barely 50%. So some countries are actually doing a better job than others. And when you look at and this is the graph on the right-hand side, when you look at the number of comorbidities that are considered as increasing the risk of severe influenza that are properly immunized, you see that even in patients who have 4 or more comorbidities, you're barely at 50% on average in the population. So there is an insight there, which is that if you don't get to recommended immunization level, you don't harvest the full impact from the public health perspective of vaccines. And so what should be the next steps? I mean, when you look at what WHO is saying in terms of what's the framework for action in especially in seniors, what you see is what you want to avoid anything that results in a decreasing physical and psychological capability, so that you don't get to essentially dependent people. So you want to essentially intervene and protect before you're at a stage where you have to protect an individual that has, besides advanced chronic conditions that require a lot of care and potentially come with a massive both financial burden and also emotional burden on the patient, but also on their families. And what is very interesting is when you look at the target vaccine profile, or the ideal vaccine profile seen from the WHO, it shows some features that are, of course, very suitable for vaccines used in emerging markets. But I have highlighted the desirable features that would apply to any vaccine if it was to be qualified as an ideal one. Of course, starting with safety, and that applies to any vaccine for seniors, you want a vaccine that has limited or no contraindications, right? Because otherwise you create exclusions and you have an imperfect public health tool. You want also, the safety and the reactogenicity to be bearable so that there's a good benefit and risk profile. And on the efficacy side, of course, you need to demonstrate sufficient clinical efficacy, but you want a rapid onset of protection. The issue with some vaccines is that it takes multiple doses and a progressive ramp up of immunity to reach clinical efficacy. Ideally, you would want something which is single dose that gives you a rapid protection, but also a lasting protection. And by the way, I'm sure you're all aware, this is the central question nowadays with the development of the coronavirus vaccines is, are they clinically protective? And if so, how long is the protection going to last? So when you look at, therefore, what kind of technologies can be used to, help, improve the vaccine for seniors, there are broadly three domains, if you will, where there's a search for technologies that can help improve or boost the efficacy of the vaccines. The first one is the design of the antigen itself. Okay, what is the active substance? Can we engineer the active substance in such a way that it elicits a stronger response? That's chapter one. Chapter two is the adjuvant. Okay, the antigen being what it is, can we add a substance that actually boosts the immune response, solicits the immune system in such a way that it amplifies the reaction? And lastly is administration route. Are there other ways, such as the transdermal route, to access, the dendritic cells, or is mucosal immunity, for instance, for an airborne pathogen, generating the production of IgAs at the mucosa level as a first barrier to entry before there's a systemic circulation of the pathogen, in which case the IgGs and IgMs come into play, and the T cells. But before that, can we start stopping or stemming the severity of the infection by acting at the mucosal level? And those three routes are being explored for all vaccines in general terms, but especially for vaccines that are applied to seniors. And so let me take a few examples to illustrate the points in vaccine-specific designs for seniors, and keeping it on the field of influenza, which is well known. And there are three options that have been tried, and you have a table summarizing what's available today in terms of vaccines that have demonstrated a clinical superiority in seniors. The first approach was to increase the dose of antigen. Essentially, it's, okay, the immune system of the seniors is not responding so well, so therefore, essentially, we're going to kick it stronger. So you increase the dose of the antigen. So that's the approach that has been taken. It's the third line in the table one, so-called high-dose inactivated. So what you can see is that it contains 60 micrograms of hemagglutinin per antigen, as opposed to the standard 15 microgram. That actually works reasonably well. Of course, it is at the expense of higher reactogenicity. So you have more subjects who report pain on injection and a bit of fever in a couple of days following the injection. But of course, this is the price to pay to get a stronger response. The second approach is to not modify the antigen content, but to add adjuvants. So this is the second line of the table. This is MF59, is a proprietary adjuvant belonging to formerly Novartis, now GSK. And essentially what the adjuvant does, it increases the ability of the dendritic cells to present the T cells, and therefore it increases the exposure to the immune cells, and therefore it elicits a stronger response. This one is also demonstrated in phase 3 as being delivering a superior response. And the last one is a recombinant quadrivalent influenza vaccine, but this one here is a kind of hybrid of two approaches. It's a recombinant antigen, so instead of growing it on eggs and isolating the virus and then using a chemical process to essentially extract hemagglutinin, hemagglutinin is produced in cells that are genetically modified to express the hemagglutinin, and on top of it there's a higher content also of the hemagglutinin, so it's a kind of a hybrid approach, if you will, between recombinant and high dose. The first line in the table is, for your reference, is the standard inactivated triquadrivalent vaccine, which contains 15 microgram of, which is what any, I would say, adults, for instance, in Europe nowadays is receiving. And so I'm reaching pretty much the end of this presentation. So what are the insights that have been derived from all this work and all the clinical activity to substantiate the value of those products? Is, of course, it starts from the known situation from the epidemiology perspective, that older adults are more vulnerable and they are at higher risk of poor outcomes when they get influenza as other infectious diseases. And also they're at risk of greater complications, which there's a greater risk of persistent disability in seniors compared to younger people, with all the social and economic impact. So, prevention is important. And even with the imperfect vaccines that were used in the past, meaning the 15 micrograms one, not high dose, not recombinant, and not adjuvanted, we've seen already the benefit in terms of public health. So clearly the insight is that continuing to vaccinate with, of course, appropriate and properly tested vaccines remains the recommendation, and there's a global consensus on that matter, and where the efforts should now be oriented is towards increasing the coverage, because this is, as you know, infectious diseases are transmissible diseases, and until you reach a sufficient degree of coverage in the population, you can't effectively block the transmission, and therefore you're still, maintaining the risk of contamination.
Thank you very much, Pierre. It was great. Thanks a lot, everybody. So if you have any question, you can quickly, I think there is, let's see, is there any question? Anybody wants to ask a question? So if not, I may ask you one question, Pierre.
Sure.
So how long we should wait up to the next to have a secure, less risk-free vaccine in Europe? I have asked you this question.
Against what? Against the coronavirus, you mean?
Yes, sure.
Well, the vaccines that are currently under development are following the norms of clinical development for vaccine. Okay, the only, I would say, adaptation is the so-called adaptive licensing approach, or adaptive clinical design, where if you got positive results, rather than pausing, you actually move almost seamlessly from phase 1 to phase 2 and phase 2 to phase 3. And this is, of course, driven by the urgency of the situation. The body of evidence which is available so far is already quite convincing. All the vaccines that have reached permission to execute their phase 3 have demonstrated in phase 2 that they're reasonably safe and that they elicit an immune response. Now, the real question is whether this response is clinically protective, and that's the role of the phase 3 trial in natural conditions in countries where you have viral circulation to demonstrate. and also as you know, the subjects of the phase 2 are monitored over time, so we will know pretty much the duration of immunity over 1 year on the phase 2 cohorts, sometimes in March, April of next year, and we will know whether this response is clinically protective towards the end of next year or early 2022. So the decision which is likely to be made by the authorities on the basis of the interim results of the phase 3, which should be available end of this year, beginning of next year, is a matter of risk-benefit balance. If the vaccines are demonstrated as clinically protective, but you still don't know how long the immunity lasts, a response, albeit imperfect, is better than nothing. So you're already seeing countries that have decided to, if the results are positive, meaning yes, the vaccines protect against the infection, even if we don't know how long the protection is lasting, we'll use them to start, stemming the problem.
Okay, thank you very much. One more question quickly, please, Pierre. Hilde Stevens is asking, is there at this point in time a different approach in vaccine development for the elderly and compared to a more standard approach for a larger public?
Well, again, the crux of the matter is to stimulate the immune system. So all the various approaches to stimulate the immune system are being tried. What you're seeing also with the sort of the boost to innovation, which the coronavirus infection is representing, you're seeing technologies that were still in the making, like RNA, which are being tried. DNA, mind you, is not a new thing, right? DNA vaccine was tried 20 years ago. Okay, and it raises plenty of programmatic challenges because of the difficulty to have the DNA penetrate the cells and elicit a response. The vector technology is more recent and has been yielding positive results. So that's what is being tried. But besides this, again, there's adjuvant and a route of administration, but not much more, because there are no other known ways to elicit a response from the immune system. You need to get the immune cells to react to something which is presented to them as something that they will have to recognize as being foreign and to be eliminated in the future.
Okay, thank you very much, Pierre. Now, can you invite Professor Dr. Sven Stegman?